At the outset, let me thank Dr. Manikandan and Dr. Kiran Jacob for giving me this opportunity. So the case that has been given to me is a 35-year-old male executive with a history of intermittent palpitation for 3 months, no syncope or chest pain, exercises occasionally, heart rate and blood pressure normal, ECG sinus rhythm with frequent monomorphic PVCs, Holter PVC burden of 12% with occasional couplets, no NSVT, echo structurally normal, normal ejection fraction, electrolytes and thyroids normal. Fair enough data, but we may need few more things, whether there is any abnormality in the native ECG, what is the site of origin of the PVCs, and the morphology of the PVCs to take a final decision. So what is a PVC? Spontaneous ventricular electrical activity before an appropriate sinus impulse is called as a PVC. It is highly prevalent arrhythmia. We all experience it at least once in our lifetime, and even in 24-hour Holter, more than 75 years, at least there will be few PVCs. How will they manifest? Majority are asymptomatic, and most common symptoms are palpitation, giddiness, a thud feeling in the neck, dyspnea, and rarely syncope. And there is no linear relationship between the PVC burden and severity of symptoms. Many patients with very frequent PVCs may be totally asymptomatic also. Other relevant history that we have to take is any previous heart disease, that to see whether there is any scar in the myocardium which can create PVCs more dangerous. Family history of sudden death like a channelopathies or a cardiomyopathies. Medications like sympathomimetic agonist, beta agonist, tricyclic antidepressant and antiarrhythmics can make PVCs dangerous. Now how to evaluate the PVC? The basic tool that we get is the 12-lead ECG. So in the ECG, look for the origin of PVC, what is the morphology, what is the frequency by extended monitoring of the rhythm at least 24 to 72 hours. Some people advise 6 days of monitoring, and look for any evidence for structural or electrical heart disease. PVC origin, to elucidate, we can take our regular ECG QRS axis. The PVCs that originates in the outflows are usually benign. So since it is originate in the outflow, the lead 1 and the AVL, which are the lead represents the outflow, will show a negative QRS complex. Since it is originating in the outflow, it will come to the apex or into the body of the ventricle. So that lead 2, lead 3 AVF, which is looking into the inferior part, that will produce a tall QRS or a predominantly positive QRS complex. So by that we can decide where is it originating. Now if it is originating in the body or in the apex, you will have a lead 1 AVL will be positive and 2, 3 AVF will be negative, just the opposite. So that is a simple technique. Now you can locate which ventricle it is arising from, whether it is from the right ventricle or the left ventricle. You have to look only the V1 electrode. If the V1 electrode is very close to the right ventricle, so any PVC originating in the right ventricle will produce a negative complex or a QS complex in the V1, while those arising from the left ventricle will produce a positive R wave or RSR pattern in the V1. So that is how you assess the site of origin and the ventricle. So here is one ECG. You can look, there is a QS complex in AVL and there is positive QRS complex in lead 2, lead 3 AVF, suggestive of it is originating from a outflow VPCs. And in V1 it is QS, so it is arising from the right ventricle and specifically from the anterior wall of the right ventricle. So this is another PVC where it is the QRS complex is predominantly negative in inferior leads and positive in AVL, so it is arising from the body of the ventricle. And in V1 the QRS complex is predominantly positive, so current is coming towards the right ventricle, so it is originating from the left ventricle. So it is PVC from the body of left ventricle. Other features that makes PVCs more dangerous are when it occurs as a couplets. When two PVCs arises together, they are called as couplets. Now, if the morphology of the PVC varies in the same lead, that is polymorphic, so that type of PVCs are also has to be taken with care. Now, the QRS width of the PVC, if the width is more than 150 milliseconds or maybe 4 squares, small squares, you have to think that that PVCs can be problematic. Now, if the PVC is falling on the T wave, in the peak of the T wave or in the descending lip, these PVCs can trigger arrhythmias like ventricular fibrillation. So that type of PVCs also has to be taken care of. Now, in the basic ECG, look for electrical abnormality like the QT interval. If the QT interval is prolonged, again, they are high-risk patients. And the other cardiomyopathies, where it will present some the repolarization abnormalities in the initial part of the ST segment, like the epsilon wave in the ARVD, they are also high risk to have sudden death. So these PVCs should be taken very carefully, and you have to follow up. And any old MI in the ECGs or any scar like seen in sarcoidosis, that can create problematic PVCs. So in short, to summarize, high-risk PVCs are if there is a structural underlying disease, ischemic or electrical underlying disease, these PVCs has to be taken more closely. More than 2000 PVCs per 24 hours can be high risk. Complex PVCs like couplets, triplets and NSPT, polymorphic, and if the PVCs increases with exercise, usually PVCs most commonly decrease with exercise and reappear during the recovery period, but if it is increases with exercise, that's another abnormal finding. And non-outflow tract PVCs can be due to scar, short coupling interval around T, and PVCs with broader QRS complexes are high risk. So the consensus statement of the ESC, the asymptomatic patients with frequent PVCs more than 500 may have to look for any other associated underlying structural ischemic or electrical heart disease. Very frequent PVCs, there are different definitions. Some says 10%, some says 20%. In this guideline, they call it as very frequent, some call frequent PVCs. So if it is more than 20%, they carries high risk for PVC-induced cardiomyopathy. And treatment of patients with asymptomatic PVCs should focus on underlying heart disease rather than the PVCs. This is the summary of recommendation after seeing the site of origin. If it is a outflow PVCs or fascicular PVCs, normal LV function and symptomatic, since they are easily amenable to ablation, class 1 recommendation for ablation. Otherwise, beta blockers and calcium channel blockers and flecainide. Amiodarone is usually contraindicated in such group. PVCs other than RVOT or fascicular, that is from the body, and if the patient is symptomatic, normal LV function, since ablation is technically slightly more challenging, beta blockers and calcium channel blockers are class 1 recommendation. If the patient has got LV dysfunction, whether it is arising from RVOT or from the body, ablation is the class 1 recommendation as the treatment, and beta blocker and flecainide. Here, since there is LV dysfunction, calcium channel blocker should be avoided. So in our patient, and if his PVC burden more than 20% and asymptomatic normal LV function, ablation can be think of. In all other asymptomatic patients, there is no need for any treatment. So in our patient, I think ablation can be said because it is he is symptomatic, or we can give a trial of beta blockers and non-hydropyridine calcium channel blockers may be sufficient. Thank you.
Thank you, doctor, for the excellent talk. As primary care physicians, we see a lot of PVCs, but sometimes we are at a doubt whether it has to be referred or can we really wait and watch. So what is the role of Holter, and is there a role for TMT testing in PVCs?
See, Holter will give you the first after identifying the baseline ECG, if there are no significant MI or any other scars, and if the VPCs or PVC burden is very little, okay, as a occasional finding, there is no need to further evaluate, but Holter will give you how much percentage. So Holter is useful if you get more than 10% or 20% of PVCs, then they may need further more evaluation.
They say concomitant PVCs are dangerous.
If the PVC is coming, two PVCs stitched together, that is called as couplets. So these couplets can be sometimes thrown VT. So that type of PVCs needs further evaluation and may need treatment.
Thank you, doctor. Oh, it's open for discussion.
Rupesh, all PVCs do not require treatment, isn't it?
Yes.
And it should not be a knee-jerk reaction. Seeing a PVC doesn't require any treatment. That is a problem mostly occurs. And he has shown amiodarone is a class 3 recommendation. It's contraindicated. And will you advise echocardiogram for all patients with VPC to know whether it's a structurally normal heart or not?
I think it is better do an echo, because ECGs can give a clue, but maybe echo will give a better idea. I think echo you can do.
And we have to know whether it is a structurally normal heart or not.
And echo is a non-invasive investigation, so I think.
And not that expensive in our part of the world. Not that expensive. It's available everywhere.
Yes.
Can VPCs lead on to LV dysfunction?
So whether the LV dysfunction produces PVCs or PVC producing LV dysfunction is a matter of debate. But if there is any scars and all these things, probably the PVCs are of secondary to the LV dysfunction. If there are no scar and there is global hypokinesia and the ejection fraction is not very low, like less than 30 or so, it may be a marker of PVC induced LV dysfunction. The PVC induced LV dysfunction will not be very severe. It will be mild. So, but if there is a severe LV dysfunction, if there are scars, then the LV dysfunction may be the cause for the PVC rather than a PVC-induced cardiomyopathy.
So we have to do a cardiac MR in that case.
Yes, that will give you more clarity to see the scar burden.
So the VPC burden is high, symptomatic, amenable to radiofrequency ablation, like certain type of VPCs.
Yes.
The
outflow VPCs and fascicular VPCs are very amenable to ablation, while other VPCs, if there is LV dysfunction, one has to go for it. And if it is PVC burden is very high, even if the patient is asymptomatic, one can think of going for ablation.
Thank you. Thank you, Rupesh.